Good afternoon or morning to everyone, depending on where you are today. We're pleased to be joining you today to talk about grateful patient and family programs and how to go beyond gratitude. My name is Meg Bailey. I'm a vice president at Graham-Pelton, which is a nonprofit consulting firm, and I work almost exclusively with many of our healthcare clients across the country of all sizes. I am joined today by my colleague Walt Edwards, our senior vice president, who is an expert on the topic of engaging patients and families and their caregivers to ultimately elevate philanthropy for all organizations. As we already said, please note that there is a copy of the slides in the platform here if you want to review it after today's presentation. And please don't hesitate to share any questions in the platform as well. We'll do our best to monitor that and address them at the end. And if you want to connect with either one of us and follow up to today's presentation, please feel free to do so. Our contact information will be at the end of the presentation. We welcome continuing the conversation. So before we get started on the content, we'd like to set the stage a little bit for you today. We'll start by exploring how grateful patient and family programs must evolve in order to be effective. We'll do this by addressing some potential limiting factors that you've likely all experienced and how those can hinder your success and what you could look out for to address them. And last but not least, we'll also share some tips on how to increase your success with your grateful patient and family programs, regardless of where your program is at in terms of whether you just started, whether you've been doing it and building on it, or you have a very strong program that has been happening for years. So with that, I'll turn it over to Walt.
Thanks, Meg, and appreciate the chance to be here and appreciate everyone joining us today. So as we think about where we're going to go in our short time together today, as we look about the continued evolution of grateful patient and family fundraising and some of the key things that we're going to have a chance to explore together, these are the driving principles we use at Graham-Pelton. And as you look at these, you'll notice that none of them are really all that shocking, except for a couple might be a little bit different. I mean, when you look at these, it's a well-known fact that philanthropy can be part of a healing process, and asking is not the job of the healthcare provider or the clinical provider. But then when we look at a couple of the other points, we can begin to look at the idea that not all gratitude is philanthropic gratitude, and so perhaps that changes the lens in which we look through things. And that's really where you begin to see subtle evolutions or kind of growth in understanding this field from the multiple perspectives. And then as we think about it, that fifth point, the data being such an integral part of a patient-centered approach, but really a comprehensive approach, and that's really helped us really drive and create this model that we call our Beyond Gratitude approach. And it really has two key parts, two key domains, if you will. The first one is the analytical domain, and Meg's going to talk to you a little bit more about that here in a few minutes as you share the idea of understanding the data you have, how to use it, and again, she'll have a chance to explain that in a few minutes. Where I'm going to spend a little bit of time today is what we call the relational domain, and this is how you reach out and engage physicians, nurses, other care providers, and really throughout your organization to build the relationships between those healthcare professionals and the development professionals, your foundation professionals, to work effectively as a team, to identify those people who are trying to, as we say, go beyond gratitude, right, to gratitude that's more philanthropic in nature, and utilizing these two approaches really help you identify your high quality prospects, those that give you the best opportunity to have an impact to the organization, and also, and I think even more importantly, create the most meaningful giving experiences for those people who are trying to do more than just say thank you, who are trying to go beyond gratitude. And so as we do this, we're going to focus today on what we call three limiting perspectives, and you can kind of think and see them different ways, but it's really about things that people think that we're on the right approach and we're doing things the right way, and it may very well be the case, but we want to expand the way you think and make sure that you don't limit your own progress and your own success without looking at a wider perspective. And so as we look at it, the first one is that grateful patient family fundraising is a mechanism for giving, and I've seen this discussed with folks even in the past just 48 hours. I've seen this conversation come up where we really begin to think of it as a mechanism, right? It's the how people give, and this limits the ways in which you can engage grateful patients and families. Even more so limits the level of fundraising, the level of giving that can happen with an organization. And probably, again, most importantly, it limits the meaningfulness that someone can get because they're limited as to how they can engage with the organization. And so I often see these mechanisms, or whether they're brochures or recognition programs, they're great parts of a grateful patient and family engagement program. But when you limit it to a brochure, or you limit it to only recognizing a caregiver, and that's the mechanism that you use, what you have focused on is really limiting the impact you can have. And what we'd rather have you look at is really the antidote to this is looking at motivation over a mechanism, right? Above mechanism. We want you to think about, the understanding of why people do this. And so when you think of grateful patient and family fundraising, it's not how people give, the mechanism. It's a little bit of that, but a lot more of the why, to get to the deeper connection, the deeper experiences that people have. And that's really the important thing, right? Is to understand that these come from positive and negative outcomes. Again, many of you will understand that and have seen grateful patient and family success where things haven't gone so well and where things have turned out wonderfully. But as you work to engage clinical partners, this is one of the things that you still have to be able to articulate and help them see, because they see things from a different perspective. In the coaching we do, that's really what this starts with. By beginning to look at motivation, you have to look at perspective and understand how people see this same moment in time. And continuing to reinforce that philanthropic giving can be part of the healing process from those patients or families that are looking to go beyond gratitude, right? Not just say thank you, but go beyond that. And I thought one of the best ways to have a chance to talk about these ideas, right? That it's not just about the outcome, but about the experience, and how healing has a chance to do this, but also combine that with the different perspectives involved, was to let you hear from a few folks who have different perspectives. The first couple are some caregivers. The third person you'll hear from is a grateful family member, but I'm gonna let them talk to you about this idea of looking at motivation more than just a mechanism that turns into a transaction, looking a little bit deeper to the principles you see here on the screen.
I absolutely agree that giving back for many patients is part of the healing, even when outcomes aren't so good. And I think, in fact, that's when many families, and even myself as a provider, feel more compelled to work that much harder. And hopefully families and donors want to give more because they realize how much work we have to do.
It always amazes me that these families can have such hardships and go through so much, things that most people would think are unimaginable. The general public has no idea what some of these families go through, and it's heartbreaking on a daily basis to see it. But I think that there's always this good in people that want to help when they can. So they've received so much from the staff, the clinicians, and the care that they've gotten for their family member. And they see that and they want to make sure that someone else has that same opportunity. So it's really amazing that even through such tragedy and such hardships, that people can think of others in those instances. So it just is really refreshing and really lovely to see.
The powerful thing about those is you saw a couple people in different roles. One's a physician, one's a nurse. A variety of people can have that impact, be part of that experience more so than the outcome. And when we begin to look at all the people that can play a role in that experience, again, many of you know it's looking beyond just physicians to other people who were part of that patient family experience. And so I'm going to look to the other perspective to share a little bit further thought. And this comes from a gentleman who's a grateful family member, but he's going to talk to you about it and really begin to give you the patient family perspective on this idea of going beyond gratitude, as well as the focus on the experience more than the outcome, even just in the words he uses. I'll let you hear his thoughts and then we'll share a little bit more about
it. If you've been rendered professional help, if you've been rendered empathy, caring, a positive experience, you will want psychologically, if you have the capacity, to give money or help in any way, shape, or form to the institution which rendered you the help. And if you've been dealt with in a very positive fashion, you want to give.
And so you hear him describe it. You hear him describe that it's a positive experience. If you were dealt with caring and empathy, things that every healthcare professional does. And so it allows you to begin working with the clinical providers and caregivers to be able to understand what creates this motivation. But notice he didn't say you have a need to say thank you. You have a need to give. You want to give. And this is where you begin to separate the idea, this evolving idea of that this is not just about gratitude. Gratitude is thank you. What we're looking for are people who want to go beyond gratitude, who are trying to do something more than just say thank you, who have the need like this gentleman. And there are countless others. While it's still a small percentage of your overall patient population, it's a larger number than people think when you begin to tune into this idea of people who are trying to express this need to do more than say thank you. And so sharing these different perspectives and working with clinical providers and caregivers allows you to recognize how they see things, but more importantly, to help them see how patients and families see it. And then we have the next challenge, which is, part of this antidote is helping them identify the people who are expressing these things. And so we often say it comes into one of these two categories when people are trying to express beyond gratitude, right? More than just thank you. And so it's a little bit more than thank you. That's a tough one because you take gratitude, then add a little bit like you see here on the screen, a little bit to that expresses a little bit more. It doesn't mean they're going to be, big donors or donors at all, but it does mean that there's something in there, an inkling of them that they have this desire to see what might be possible more than just the hug or the high five or the elbow bump these days or whatever it might be, to go beyond that, to see, is there something that would be meaningful to me? And this is where we want to be careful not to turn it into a transaction. We'll talk about that. Even more, that same cautionary note, when you look at the other big bucket of ways this is expressed, the motivation is that direct offer, that offer of support, the key questions. You see a couple of examples of there, and there's countless examples of those that could happen. But these are often wrapped in a lot of emotion, also frustration, anger, pain, I want to do something, and sometimes joy and excitement as well. And so that emotion sometimes will push people away from engaging with folks. And you just want to be able to work and coach with folks. And so again, it's a lot of what we do, but I think good healthcare providers are receptive to someone who understands the different perspectives, can articulate it to them, and as a development professional, being their partner in working through this space with them and helping them understand the different perspectives, understand the motivation, not just the mechanism, is the way to a larger, more meaningful gift many times, and how they can begin to navigate this. And we'll talk more about that next part of helping them navigate things here in just a moment. Really, this idea of shifting from just beyond a grateful patient and family mechanism, a brochure that lets you write down an amount or a name, it's a wonderful thing. But the big opportunities and the meaningful giving opportunities from the donor's perspective and the patient family perspective are those that go a little bit deeper and are about a conversation to find out what would be meaningful to them and that referral process. And we'll talk a little bit more about that here in just a few minutes. The next limiting perspective that we've seen a lot of, and we see it more and more, is this idea that all you have to have is some great data. You just have to have the new shiny gadget, Wizmo, thingamabob you plug in, and it's going to tell you all the people. You over rely on the data to run your grateful patient family program. And I'm going to let Meg share her thoughts around how to overcome this and the antidote, if you will, to really thinking about better utilization of your data and what it really means to have a robust analytical domain. Meg, I'll turn it over to you.
Thank you. Yeah, as Walt said, it is a common misconception that all you need is the data, whether that's screening all of your patients or trying to do a well screening analysis to see who the top prospects are. And while that's an important component, it goes far beyond that. At every organization, the cultural acceptance of grateful patient and family fundraising can vary so greatly. And that's why it's so critical to identify your organization's current level of acceptance when it comes to patient data, as well as how you're going to work with medical professionals in the fundraising process. This is important to be able to determine a path forward. So the antidote here really comes down to leadership, but it shows up in a few ways. When referring to institutional leadership, it's so important to be able to socialize this program at the highest levels, to be able to gain buy-in from executives and others that are key decision makers. Because if they're on board with the implementation of it or expanding of a program, it's going to be that much more successful. We've seen this time and time again with our clients. If the CEO or the president is deeply involved and can give that green light, especially when it comes to providing HIPAA compliant patient data to the fundraising team, it prevents many hurdles and helps you become more successful, because you need to have that approval from the necessary parties, whether it's your HIPAA compliance office, your business intelligence or IT teams. Everybody needs to be on the same page and understand this is an institutional priority and it's coming from the top to inform your efforts. In terms of integration, what's also important here is exploring not only the compliance issues that could come up, but also looking at your electronic medical record system to see, is that integrated or accessible enough to you in a HIPAA compliant way, so you can use the right data to identify the right prospects for your program. And this serves as a complement to those clinical partner referrals. You know, as Walt said, those interactions help identify the patients and families that want to go beyond gratitude, and that analysis or feedback is so much and more important in some instances for organizations than just seeing the spreadsheet of the names and the service areas of a potential patient, especially for an organization that might have a significant population where perhaps Medicaid volumes or others are automatically being removed from the process and might not give you, a wide variety of thousands and thousands of records on an ongoing basis. So the integration is important, but keep in mind that it's not the end-all be-all, but it is helpful to make sure that the integration comes into play with your development or foundation systems and processes, so that you can actually use the data to use it in a thoughtful way for your purposes. And what's helpful here is thinking about what scalable or repeatable process can exist to help you maximize the pipeline. Obviously, staff bandwidth varies with every organization, and so not everybody is going to be able to screen patients every single day or have a list that identifies those patients in the hospital at that point in time. But you need to think about what's realistic for you and be able to repeat that so you can proactively identify the data to complement what you're receiving on the other end through the relational domain with those caregivers. And this all leads to a patient-centered approach. You know, if you can utilize the data and gain the appropriate approvals, this will impact the outcomes for your program, because it will impact the relationships that you can build with patients and families. You know, a classic example might be if you're able to see a service area or a department for a potential patient that's come through on the data side, this can suggest potential gratitude indications and help you prioritize your efforts beyond those referrals from the healthcare professionals. This goes back to the analytical domain of identifying viable prospects through the integration and data analysis, so that you can be patient focused in your approach and outreach and prioritize looking at the right people who are more inclined to be grateful to your program and also more financially able to support with philanthropy. On this next slide here, this graphic shows you sort of in summary what's needed for a successful relationship with data at your organization. So we would encourage you to think and reflect about where your institution might fall when it comes to having executive buy-in at the highest levels, compliant systems and processes that can help you identify patients that might be grateful, and also how your data can be utilized and analyzed by your team to focus on forming a patient-centered approach. All of these together are absolutely essential to supporting your program. But again, data is not the end-all be-all. It's a complement to what we see in the relational domain with working with gift officers and also the care professionals that can help signal and identify those potential prospects that ultimately will go beyond gratitude. With that, I'll turn it back to Walt.
Thanks, Meg. When we look at our third limiting perspective, I know this one won't come as a shock. People think, well, this is not real limiting. We as development professionals and foundation professionals understand that physicians don't want to ask for money. So how is this limiting? It's really limiting from the fact that it's still the number one speed bump, if you will, or resistance point that we get in the coaching and the training that we do with physicians. And even in whether it's large sessions or whether it's small one-on-one coaching, this is still the number one point that limits the perspective. And so helping them understand it, they're exactly right. They're not the ones who ask for money. We don't coach them, we don't train them to do that. But there is something that they can be aware of, and that we want to have them be able to grab those, what we saw a few minutes ago, those signs and symptoms of philanthropic interest, right? Those beyond gratitude indicators, those little bits of language that people will say are things they can get, and they can become engaged to the extent that they want to. But this comes into a deeper understanding of the physician perspective around the idea of engaging grateful patients and families. And so we want to think about this idea, reinforce that they're right, but then find and clarify the role for them that fits where they are. And we'll talk a little bit more about that as we move forward. So really, this is about helping them build skills and confidence, right? Helping them find their voice rather than saying you don't have to ask for money. That's great, but then take a step beyond that, right? Go a step further and say, but you have to find a voice, your voice, in this space, which means it's going to be unique to them. And as you'll see in a moment, it's even unique to the individual situation. We'll talk more about that and give you a way to think about that here in just a moment. But when you help them do this, it's about giving them a way to maneuver, giving them the flexibility to be who they are. And so when you go in to work with them to find that voice, it's not telling them what to do. And that's the number one thing we hear with folks. They've been told what to do, but what they don't know is how can they do it. And so we share them, and we'll tell you here in just a couple of moments, as you think about how to help them overcome that build that how, find their style. Don't give them the solution, work with them to find where are the real points of discomfort. Find them and then help them navigate over each one of those speed bumps rather than let them be complete roadblocks. And I thought I would share a couple of physicians talking about this idea of removing this right off the bat. We don't have to ask for money. They're not going to have to do it. What allows it to do, and from their perspective. But they also give one in particular, a couple other key things to recognize as you help them see this from a different perspective and recognize some of the depth and challenges around the physician perspective. But here's a couple of their thoughts.
I think faculty often think that for me as a faculty member to get involved with philanthropy, I have to learn how to ask for money. And we have professionals for that. What it's about is relationship development.
I think there's no question about it. If you took me out of the equation for actually asking grateful families for money and had someone else do that act, I think it would definitely ease any kind of anxiety.
And so you hear them, as soon as I don't have to ask, that's great. Other people can do that, right? Well, that's exactly who the development professional, the foundation professional, that's exactly who they're referring to there in a good mutual respect team type of environment. The first person says, it's about relationship development. Well, it's interesting because this is where, again, knowing their voice, where their perspective is, helping them realize that physicians and other caregivers, they have a relationship already with that patient or family, right? As that caregiver, that's their primary relationship. So what we have to help them do in finding that voice is recognizing that, and helping them find a way to be engaged in this is recognizing that this is a different aspect of that primary relationship. I often think of it as they have a tree trunk, right? That the big tree trunk, that's their primary relationship as a caregiver with that patient and family. And this is just a branch that grows off. I mean, many of you are probably familiar with physicians who would say they become friends with patients over the years, or other people who've built different types of relationships. This idea of wanting to do more than say thank you, going beyond gratitude is a branch that grows off. And they're allowed to go out as a healthcare professional to the extent that they want to or are comfortable doing that. It's your role to help guide them in that process to that point that they're willing to engage, and then drive that strategy and lead that strategy forward for them. And so each one of those is going to be a little bit different, but recognizing that they're always going to see that caregiver-patient relationship, caregiver-family relationship, that's always going to be the primary one. We just don't want them to hack the limb off because they're uncomfortable with it. And that's an important aspect to recognize, is that, and you can see the second gentleman there, this whole topic's just not something he's real comfortable with. And we've had people, and I've worked with folks over the years, that will tell you they're still not comfortable in this space, but they're highly successful in it. So I would encourage you not to share with people that you're going to make them comfortable, or you want to make them comfortable. You want to reduce their discomfort to the point that they can engage in this process and help you identify those people who are trying to identify themselves as wanting to do more than say thank you through the language they use, or perhaps thank you notes and cards that we mentioned also, that were referenced also in an earlier slide. Which brings us to an interesting thought about this. When we begin to think about helping them find their voice, I'm going to share with you a tool, Continuum, and folks have probably seen this or something similar to this, but really like the way this thinks, but it's evolving the thought behind this, because most times it would be looked at from a macro perspective where people would ask a physician or another caregiver, so how do you feel about engaging grateful patients and families, right? And you see the different blocks in there, and they may be at a different place between them. And you see what the optimal engagement is, right? I'm regularly engaged in this process. I'm really even willing to even be proactive, which is, through some added language or what we call passive awareness, through visual cues and so forth. But that's where you love people to be. And they say, yeah, I'm kind of, or I might be over here not quite optimally, but I'm occasionally engaged in this. And of course, then you see the two ends of this continuum don't want to be involved. And those people who ask too quick and tell you all I have to do is, have lunch with somebody and they're going to give me a gift. I want to look at this idea, though, that from a macro perspective, when you ask somebody, they're going to put themselves kind of in one of these things. The way they describe it will allow you to place them on here. But then, and that's from a concept, right? You've asked them about the concept of engaging grateful patients and families. But then if you put 5 names, and we've done this exercise many times, where you put 5 names down, 10 names down, and suddenly they're not all in the same place because the relationship is different. That's the micro placement on a continuum like this, and a lot of people just overlook, right? That's the, what to do. I want you to regularly be engaged. I want you to maybe even think about bringing up the topic, right? But from a micro perspective, you have to help them find their voice in these different situations, which is really around helping them create the idea that each one of these, each patient family, each situation can be in a different spot, might be in the same spot, but they have a different relationship with them. So you give them the flexibility that their voice, their level of comfort and or discomfort, however you'd like to describe that to them, and engage in that with them, it can be different based upon the situation, based upon that unique moment. And so when you begin to work with caregivers and physicians and other healthcare professionals, recognizing that, where you were last time with the last situation may be the same or may be different, that there is a difference between macro placement and micro placement with each person. And I thought this idea of having this different position is really sometimes about preparation. So I was going to share one more video with you of a person who describes that this idea of finding that voice. And she describes a little bit differently, but finding that voice is really such an important part of getting a robust engagement from somebody as a physician or a staff member.
I think it can be an uncomfortable conversation if the physician or the staff or whomever is having the conversation with the family doesn't know how to frame the conversation. When I've been approached by families, I've asked them very simple questions of, what has meant the most to you? How would you like to give back?
And I'm going to leave this screen up because I want you to see the text there. In that very first few words, an uncomfortable conversation. And that's exactly what this is for a lot of caregivers and healthcare professionals. It's an uncomfortable conversation. And we all know what we like to do with uncomfortable conversations. We like to avoid them. And that's why I describe this as we're going to try to reduce that discomfort, right? Make it less uncomfortable to help you understand and build that framework out for somebody. And so when she describes it, when they don't have an idea of how to frame that conversation, how to build it, we actually look at it with just 3 simple parts, with the idea that when you think about how to respond, because a lot of people, they'll hear it, and sometimes they'll tell you that they don't, but they actually do, but they're just not sure how to respond, how to engage, what's the right thing to say next, rather than give them script, because we don't believe it's about scripts, because scripts don't fit into that macro and micro idea of placement, because a script that worked one time might not work with the next time. And now as a caregiver or a physician, I'm kind of thinking I'm a little awkward here. I'm not sure how to navigate. So rather than a script, help them find their voice by giving them a simple outline, which only, when they hear one of these signs or symptoms of beyond gratitude, right? When you hear someone just beginning to describe this, it really is about just 3 pieces, right? I acknowledge I heard somebody. I offer to make a referral or a connection with to my colleague or my team member who's helped other people in these situations, right? That's the development office of the foundation. And then I reassure them right away that care is still their primary focus, that we're here. I appreciate that. And again, I'm not going to go through all the language examples that can be used, but the idea is have a few examples and be able to walk through them, but remind them right away that after you've acknowledged and after you've offered to connect them, that you reassure them that right now we want to make sure we're taking care of what's going on medically. The situation is here. I sure appreciate that. Appreciate your kind words. I'd love to connect you with one of my colleagues that has helped me with other folks who've mentioned similar things, and that'd be comfortable for you. I'd like to put the two of you in touch. Right now, though, let's make sure we talk about what's going to happen between now and your next visit, what you can expect. And if you look at that from, and this is really a great thing to share with them, right? Because you're working on the discomfort from the one perspective, but as you come around and remind them, think about this from the patient family perspective. Somebody heard me, somebody offered to help me, but primarily they're still going to take care of me. You can work on what happens next based on their response, and there's ways to navigate through that as well. But that when you give them that simple outline and then sit with them and talk about what that might sound like in those different situations, somebody they know really well, someone they haven't met, right? Then you begin to help them find their voice. And when you begin to help them find their voice, that's what's going to that's going to be a big ingredient to reducing the discomfort, making the conversation less uncomfortable, which is going to give you a better chance to engage folks in a different, at a higher level and in a much more meaningful way. So that's when we talk about finding their voice. Now, what we also do is when you think about this for an organization, you know, it's you want to think, where do I start? How do I begin to think about this? And you know, where's the right place to begin? So we actually look at, we think the best thing to do is do an assessment of the people you'd like to engage, physicians, by department, or wherever it might be. But we actually utilize a process that allows you to come in, and if you think of a grid, right, to help create the buy-in and figure out where the best place for my limited resources to go. And that limited resources might be funding, it might be staffing, it also might be service lines that your particular facility or medical center hospital offers, because not everybody has the same service lines. I know it's an obvious statement, but it's something that has limited people from getting engaged with grateful patients and families because they may not think we have the right service line. But we'll utilize a series of conversations, utilizing the continuum you saw before, but also then begin to think about where are the places to utilize your resources, look at this with different service lines, different payer mixes, and begin to think about where are the best opportunities to engage folks as part of a strategy, right? Part of a way to roll into this process. And so as we think about that, we've shared, you know, 3 limiting perspectives. We've shared some antidotes, some ways to overcome things. But when you go beyond gratitude, right? When you look beyond where things have been to understanding the perspectives and understanding how to use data and understanding how to really create a better level of buy-in from people you're trying to partner with internally, these are the things that can happen. And I'm not going to read through each bullet point. You can see them here and read them much faster than I could ever read them out loud. But these are the things that build success, right? Not just success in a moment, but when you follow this process and you look at these types of approaches, you begin to build sustainable success, growing success, and avoid some of the biggest challenges that people have had in the start, stop, grateful patient and family programs over the years. This builds something that is scalable, allows you to fit it to your organization, start where you can build momentum, find success, and then begin to build a case for further investment and further growth based on the results that you've had. And so that's, to me, that's the best way to get that ownership and that buy-in of everybody that's involved in that process. So that's where the content we wanted to have a chance to share, that wraps up our particular parts of the content today, just as a way to think about things. But we also wanted to leave plenty of time for some questions and hopefully some answers that we can share to the questions as we go through. So Meg, I know you're much more proficient at monitoring the questions than I am. I'm not sure if any have come through or if there's anything that we can address right now.
Yeah, so we'll give people a minute or two to think of any questions they might have. But one that I imagine might be top of mind, Walt, just given what we've seen with our clients time and time again, is you've alluded to the service lines and different focus areas and how prioritization efforts can come into play. Can you speak to how, in your experiences, you've coached either fundraisers or the caregivers on a nuanced approach that aligns with their service line? So how do you change the approach for, let's say, a surgeon compared to someone who might work in the emergency department? Obviously, every organization is unique, but are there any high-level trends or themes that you've come across that might be helpful to the audience?
Sure, and it is a very common thing, Meg, so I appreciate you asking. There's 2 actually pieces of nuance that you've touched upon there. The first is when you do look at service lines or specialty areas, there are differences in the way that you approach things. So when you think of it really based on the frequency that somebody has to engage the same patient or family. And so when you think of that, how often they're going to have a chance. Some surgeons they're gonna have one follow-up time and that's it. And so they're gonna have to be willing to be a little bit more proactive in some of the language, similar to emergency medicine, emergency departments, to increase their chance of opportunity. They have to be willing to be a little bit more proactive. And if you can, then you can increase that number. Still challenging areas. And proactivity is not trying to get someone to, it's not making an ask, it's not going far. It's really only adding a handful of words many times to what happens, but to words they're already using to respond to people. But it is very different there than some other surgeons may have 3 or 4. I know, for example, my orthopedic surgeon saw me one time after each surgery. I know I've worked with some, and we've worked with some surgical oncologists that will see people for 5 years. So even within surgery, there's differences. And so rather than going in and saying, here's what to do, explore and understand how many times did they see people, and recognize and share with them the other part of that nuance, Meg, is it's not waiting till something is completed, right? Because that's focused on the outcome. During the experience for people who do have high frequencies of engagement, that opportunity, that mindset may come from the patient or family at any point in time during their experiences. It may come early, may come in the middle, and it may happen toward the end. The other larger nuance that you mentioned, when you mentioned staff, you mentioned some other folks, nurses and so forth, is the idea that the approach is subtly different when you begin to work with other care providers from physicians. And again, I know a lot of people will be aware of that that are joining us today, but being able to articulate that and talking about that and what you're asking them to do and how that happens. Because one of the clips we had was a nurse, different approach with nurses, physical therapists, spiritual care, other folks that are involved in that patient family experience, subtly different but important differences than working with physicians.
Great, thank you, Walt. We also received a question related to the patient data and sort of how that's used to determine next steps, and also any tips related to leadership buy-in. So these are very related and speak to both domains in terms of the leadership buy-in, but especially with the analytical domain, this is absolutely essential to even get to the point of accessing patient data. And so some recommendations around that really include making the case for leadership. Not every CEO or president of an organization has the knowledge that the fundraising staff might have around what is actually possible through HIPAA. There were guidelines and regulations that were released years ago that stated certain data points were accessible for fundraising purposes. Obviously, everyone needs to have the ability to opt out, but in terms of the fundraising team having knowledge of a date of birth or a service department or a physician name, these are all key fields that are possible. And so being able to share the regulations with leadership, make the case for why it's used, why it's best practice, and how it can help filter out the patients that won't be strong prospects is a great way to get them on board. This can happen over one conversation, this can happen over several. So it really varies based on your leadership and your cultural expectations. But we've seen with many of our clients, it might take an email to the CEO to get the green light, and that's the best case scenario. But it also might take months and several conversations to get the right people in the right room to have the buy-in needed to make this possible. When assuming you have all the approvals that you need to move forward, the most common data points that we would look at would be obviously the patient name, any spouse contact information, their contact information, if that's in the record system. I'm looking at their date of birth, filtering out anybody who might be on Medicaid or charity care and obviously will not be a strong prospect. Those are just some of the key examples. It really comes down to what your institution is comfortable sharing, but there are many data points that are accessible to you. So I'd encourage you to look more in detail about what's required for HIPAA and what your organization is willing to do. But that helps determine next steps. So again, you can see if you're seeing a trend of hundreds of patients with wealth coming through and being attributed to one specific physician or one service department or location, you obviously don't know anything about their diagnosis, nor do you need that for that qualification process. But it gives you some tips and tricks for how to prioritize your efforts and move forward when it comes to staffing and outreach and being able to engage, again, those clinical partners. If you don't have a staff of 30 gift officers, being able to staff tons of clinical partners, being able to look at the data for those early trends can be helpful for prioritizing your efforts as you scale up. we did receive another question, Walt, that I'll ask you to address. So when we're trying to coach and not just say, this is what we do or how we do it, and it's no big deal to be doing this, what are some best practices that to get clinical teams to realize that the conversations you're talking about can actually be more valuable and productive?
So I'm going to have to make a little step of understanding around when I think of the conversations with the patients and families that you're asking healthcare providers to have. Is that the context you're thinking of, Meg, in that question? The best you can.
I believe so. The best I can interpret it, yes.
Yeah. So part of what you're looking to do here is you're trying to help folks understand that what this is really part of is identifying those people who have this need or desire to want to do this, and they are in the absolute best position because of the unique nature of the relationship. Right? You always reemphasize that this is not about asking for money, and the phrase I like to use is, I'm not trying to close a transaction, I'm trying to offer a conversation with somebody. Because like anybody, the chance to find out what would be most meaningful and appropriate for them to do is what we're really starting the chance to be able to do here. And when you talk about that it's only for that subset of patients who are trying to identify themselves, this doesn't happen to everybody, but because of the unique nature and the trust that they have in that caregiver, the patient families will often bring this up because they're in the middle of that experience with them. And when they're in the middle of that experience, that's when they're the motivations are highest. They're trying to figure out, what can I do? And all we're asking the caregiver to do is help navigate to somebody, like any other referral in an area that's not their expertise, to offer a chance to find somebody who can guide them and talk to them in that situation. I have found that this is where having a really strong trust-based relationship with the various service areas and the staff and the healthcare professionals as a development or foundation professional really matters, so that they know you're going to take the same level of care in the way you approach people as the care and approach that they give with their patients and families. I think that's part of it. The other thing I'll say, Meg, is that I have found that a lot of people will still hide behind the fact that they say they don't have time for this. And rather than tell them it doesn't take much time, there's two things to look at being able to do that I think are really important. And again, building this moment in time is that you're not asking them to interrupt the conversation that they're having and then send you a referral, but it's really saying, you're already in this conversation. It's 30 to 40 seconds, it's already happening. I'm just asking you to think of the response a little bit differently, because it's someone who's trying to do something meaningful to them. If you don't let them do it here, they're going to go somewhere else and do it many times. And so we want to give them that opportunity here, because that's what's important. And then just finding what the right mechanism is for, and let me use a different word because we talked about not a mechanism, what the best way for them to get you that information is. Where a lot of these things break down in working with caregivers is that they say, here's the way you're going to give me the information you get from patients and families. And I think that's the wrong approach. I think it's really about asking the question, what's the easiest way for you to help me, you or your team, get me the information that we're allowed to have in these certain specific situations. I know I've shared with you that I had one hospital that had 3 different floors, 3 different nurse stations, all took 3 different approaches to gathering and how they would respond to that. So to me, that's the best I can do based on the way I think the question's been positioned.
Thank you. That's helpful, and it transitions nicely into a next question. So let's assume that a fundraiser and a caregiver have a solid relationship, and they've agreed upon a way for the physician to share a referral that's easy for them, so there aren't many barriers there. How do you suggest handling certain care partners on the continuum who might fall into that overly engaged category, where maybe they're so engaged, which is great, but they're giving many referrals for various reasons, and they might not always be the most productive referrals, but yet you don't want to discourage the enthusiasm and the fact that they are making philanthropy a priority. So how do you suggest going about sort of handling that situation while still preserving the willingness to get involved in philanthropy?
Yeah, I think I have to tell you, it's a fascinating question, because I don't often get many times we have people who are overly engaged. So I think it's a great perspective to explore. I think part of it is the way to approach that caregiver or physician or whatever role they might be is to say, part of what we do is a continued learning. Just as happens in medicine, we learn from the experiences we have. And what we want to be able to do is that you, as let's say it's a physician, only have limited time to be involved in this process. So one of my continued learnings is how do I use that limited time most effectively? And that is really focusing on the best prospects, the people who are the most motivated and most likely to want to begin to continue this process. What helps me there is to really focus on, are we getting the best referrals? And so the first thing we talk about is, remember, a referral is not someone who expresses gratitude. A referral is somebody we want referred as somebody who expresses something that's beyond gratitude. And this is an unintended consequence of a lot of the approaches people take, where you tell a caregiver to focus on gratitude, and that's thank you to them. I mean, we've seen that in the over 1,700 individual coaching and conversations we've had face-to-face with caregivers. That's how they equate it. So it's helping them see, as we learn about this, and the way to get the best results, just as they like to get the best results in their field, is to say, one of the things it's showing us is we really want to focus on people who have given us this information, who say these things, or who exhibit these types of actions, so that these are people who are the most motivated, so I can utilize the limited time that we have most effectively. That's one piece. The second way, if they're overly engaged, is asking too quickly, I think it's great to be able to coach them to say, I appreciate the enthusiasm, and I think I really think it's great. But we also want to begin to think about that we don't want to make this a purely transactional experience, because then that has a chance to diminish that healing impact that somebody gets. When you give them a chance to have a conversation and find out what's the most meaningful way for them to give from that patient-family perspective, and that isn't always the transactional methodology through the mechanism of a referral card or just that initial ask, but give them the chance to explore that, you'll find that healing aspect of the philanthropy is even greater. And that's really the key part about what we're asking them to do. Those would be a couple of the ways I would do that. I do think it's an unintended consequence of people focusing on the wrong word. And there are some organizations that have driven so hard this idea of a metric of referrals, particularly from physicians, that it's all about the number of referrals I get rather than the quality of referrals. And that's why we like the approach of looking at the quality and the right type of referral.
Absolutely. Thank you. So the next few questions we've received all touch on the theme of the ethical implications that come up with this work, either with caregivers or even with leadership, especially if someone's not well-versed on fundraising or deeply involved in the way that we are. They might not understand that it's not a violation of the Hippocratic Oath, for example, or it's not a violation of HIPAA regulations. Do you have any advice, though, for either working with physicians or caregivers or even leadership on how to really show them and convince them that this isn't a quid pro quo, this isn't going to damage the caregiver relationship with the patient or family? Any advice you have? I know you touched on this a little bit, but it'd be helpful to hear some specific recommendations and ideas you've had from your experiences on this topic.
Sure, a couple of things. I appreciate it, and it's a really good point, because I think you've touched upon a couple of great starting points. Right, here's what HIPAA allows us to do, so we're not breaking anything there. We're in compliance. Your Hippocratic Oath for the physicians, it's in compliance there. And this is where I might add a little piece to it. One of the things we have used, and I've used for a number of times, is the AMA, the Council on Judicial and Ethical Affairs, actually utilizes this same in much fancier language than I use. But the idea that when someone initiates a request for fundraising information, the right thing to do is refer them to someone in that area, or give them some information. And so we're really kind of following that same lead, right? Because we're not approaching everybody and saying, hey, do you want to give? We're looking for those indicators of people who want to have this conversation but aren't quite sure how to do it. And I say that because it's easy if they say, hey, how do I give money, or how do I give back? That direct one is easier. That little bit more than thank you that we talked about is a little bit harder. But the idea is that these are still people who are simply trying to have this conversation with us, and we want to be responsive to that. So it doesn't really in any way compromise our ethics, because this is exactly what the AMA says to do. The other aspect of this, so when I really begin to think about it, is that if I'm trying to have this conversation with somebody, right, as a donor, as a patient family member, we don't know how it works. And so we're just trying to have this conversation with somebody because it's really important to us based on the experience. And so what's more damaging to a physician-patient relationship is when someone ignores me when I'm trying to say, I just wish I could find some way to tell you how much this means to us. The time you spent with us, with our family, working through this, and I know things didn't work out, but you really helped us in this really rough time for us. And this, you know, when you ignore that because you're not sure how to navigate or how to respond to that, that actually damages your relationship with that patient family, whether you're a nurse, another staff member, a physician, because this is a really important thing to them. So being able to respond, even just a real simple way that, you know, those three things we talked about, the acknowledge, offer to connect, and reassure that, you know, their care and their experience is still the utmost priority. Just being able to do that builds that relationship rather than diminishes that. And I know that you've heard me say from a personal experience as a grateful family member, I've been through that with situations in our family where we've been ignored. No one, just as if we didn't ask it, and that's much more damaging to the relationship I have with that person and that organization than it was where someone engaged with us and then helped us have a conversation later down the road.
Absolutely. So another question we received is one that I think is most likely on the minds of many listeners. I know I encountered this in my former role as a gift officer. How many clinician relationships would you say is the sweet spot? Well, you know, obviously if there are hundreds of physicians or caregivers, and that's not even factoring in all the other allied health workers that could be involved, you know, when we're prioritizing our efforts, how do we find that sweet spot? Have you found with organizations in your years of experience that there is a sweet spot? Does it vary?
You got the perfect answer with the last few words there, Meg. It really does. And I think about this, and I've got some folks that, you know, that we work with that are trying to say, you know, try to build 4 physician relationships. But what I really look at is this, and I think it really is a matter of sitting down and having a conversation. When you think about how you want to roll out your program, the structure of your place makes a big difference. You know, when you look at some of the academic medical centers where the hospital's run by a system that's separate from the institution or the med school, and that's a different dynamic, right? Who they may want to engage is very different than someone who has a system there where the university runs the med school, runs the hospital, runs the healthcare system. That's a different mechanism or different strategy as well, different platform. So it really does vary. What I ask people to think about is it's really trying to manage the right kind of referrals. Where can I get the right referrals? And that may be from the physicians. It may be, at some places I may not have access. It may be private practice docs that I don't really get to have that relationship with. Ooh, but in the infusion center, I have nurses who spend a lot of time with folks. Maybe it's orthopedics, but then I only have a couple of orthopedic surgeons, but we have such a strong, robust physical therapy program that maybe it's the physical therapists who have the longer relationship. So it really does vary. I don't think there's a specific sweet spot that's a one size fits all, because the organizations are very different. And that's really just part of building a program that fits your particular place at your particular time with a pathway for growth and sustainability.
Absolutely. And I would just add to that I think the sweet spot, even if you feel like you found that with your own portfolio or working with clinical partners, it can vary even depending on the priorities that you have. If you're in a campaign or a mini campaign effort that relates to a specific service line or area, that can certainly drive activity. In my former role, it usually included 30 or so physicians alone, looking at 10 plus programs, but then there were those few, or 5 to 10 or so, that you spoke to more frequently and really got into a groove with. But that was often driven by the potential in the pool as well, because you want to be strategic while also being thoughtful and receptive to the feedback you're getting from the clinical partners you've been working with. Great. So we've addressed, I think, nearly all of our questions, but we might have time for a few closing thoughts, Walt. What do you want to leave the audience with? And knowing that we've covered a lot about the relational domain, sort of what helps our organization stand out, thinking about going beyond gratitude. We've talked about the analytical domain in terms of really focusing on those quality patients to have that patient-centered approach. If you could think of a few takeaways that really would help any program, embolden their efforts, what comes to mind for you?
I think first recognizing that these are two really important domains. Analytics is an important piece. That's great. But understanding how to use it is also important. The relational aspect of things, trying to think through where are the right relationships, how do we build stronger relationships, and how do we reinforce them from the people we want to engage with. I think both of those are really important. I think when you think about building relationships, that most successful and meaningful and ongoing relationships don't start with, I'm going to tell you what to do in our relationship. It's more of how do we build a meaningful relationship together? And that's the approach we really talked about in helping people find their voice and understanding the different perspectives involved in these relationships, rather than just tell them, here's what you're going to do in our relationship. I think that's an older approach. I think it's limiting, and I think this is a way to evolve beyond those things to build the right kind of relationships, whether here or just about any type of relationship you look to build.
Yeah, that's a great point. Well, thank you again, everyone, for listening today and for all of your thoughtful questions. We've enjoyed going back and forth and talking about what's top of mind for you and sharing some content today. As we said before, if you have any questions or we didn't address yours in the way you thought today, please don't hesitate to reach out to either one of us. You'll see our contact information here. We're happy to be of service and continue the conversation with you. But thank you again for today, and we hope you have a great rest of the week.
Thank you, everybody.